Pulmonary ventilation, also called breathing, consists of two phases: inhalation, which is the movement of air into the lungs, and exhalation, the movement of air out of the lungs. Our ability to breathe is based on an important relationship between volume and pressure. This video will examine how changes in volume lead to changes in pressure that ultimately affect the flow of air in and out of the body. There are 8 important structures in the respiratory tract. The nasal cavity, paranasal sinuses, pharynx, and larynx are part of the upper respiratory tract, while the trachea, bronchi, bronchioles, and alveoli are part of the lower respiratory tract. Inside the nose, there's a sticky mucous membrane that lines the nasal cavity and traps dust particles. Tiny hairs called cilia help these particles move to the nose, and then they are sneezed or blown out. Sinuses are hollow spaces within the bones in between your eyes, behind the cheekbones, and in the forehead. They produce mucus to trap dust, pollutants, and allergens from entering the body when we breathe in. They also warm and moisten the air to prevent the nose from becoming dry. The pharynx, also known as the throat, is a muscular cone-shaped tube inside the body that forms a continuous passageway for air, food, and liquids to travel from the nose and mouth into the lungs and the stomach. The pharynx aids in swallowing and speaking. The larynx is a hollow tube that connects the pharynx to the rest of the respiratory system. It lets air pass from the pharynx to the trachea and into the lungs. It also helps you swallow and is known as the voice box. The larynx contains the glottis, which are the vocal cords, and is responsible for the production of speech. The trachea is a long U-shaped flexible tube that connects the larynx to the lungs. This is often known as the windpipe. When inhalation occurs, air travels down the trachea, then splits up at the bifurcation called the carina. The bronchi are 2 large tubes which carry air from the windpipe into the lungs. There is a left and a right main bronchus that carries air to each respective side. These tubes then branch into segments that look like branches of a tree. Bronchioles are smaller air passageways inside of the lungs. The bronchioles deliver air to air sacs called alveoli, where gas exchange can occur. Alveoli are tiny balloon-shaped sacs where gas exchange occurs. They are arranged in clusters throughout the lungs. The walls of the alveoli let oxygen and carbon dioxide pass to and from the capillaries, which are small blood vessels. There are about 600 million alveoli in the lungs. The conducting zone consists of the nose, the pharynx, the larynx, the trachea, bronchi, and bronchioles. These structures form a continuous passageway for air to move in and out of the lungs. The respiratory zone is made up of the respiratory bronchioles, alveolar ducts, and alveoli. These structures allow for inhaled oxygen to diffuse into the lung capillaries in exchange for carbon dioxide.
Pulmonary ventilation is depend on 3 types of pressures: atmospheric pressure, intrapulmonary pressure, and intrapleural pressure. Atmospheric pressure. It is the amount of forces exerted by the gases in the air surrounding any given surface, such as the body. It is expressed in the atmospheric unit, which is 760 mm of mercury at sea level. Intrapulmonary pressure. It is the pressure of air within the alveoli that changes during different phases of breathing. It is also called intraalveolar pressure. The intrapulmonary pressure of alveoli equalizes with the atmospheric pressure because alveoli are connected to the atmosphere via tubing of the airways. Intrapleural pressure. It is the pressure of air within the pleural cavity between the visceral and parietal pleura. Due to certain characteristics of the lung, intrapleural pressure is always lower than intrapulmonary pressure. Intrapleural pressure remains approximately -4 mm of mercury throughout the breathing cycle. Transpulmonary pressure. It is the pressure difference between the intrapleural and intrapulmonary pressure, which is approximately 4 mm of mercury.
So now we want to breathe in. We're going to move to phase 2 just below. If you recall from the information given a minute ago, during inhalation, intrapulmonary pressure decreases and becomes less than atmospheric pressure, and this pressure difference causes air to flow in. Our thoracic cavity expands, our diaphragms contract and flatten, the alveolar volume increases because all the sacs are filling up with oxygenated air, and so the intrapleural pressure, remember that's the pressure inside the alveoli, is going to decrease because there's more space being made available. At the end of our breath in, the intrapulmonary pressure will equalize with the atmospheric pressure seen in the diagram at phase 3. Now we want to breathe out. Looking at phase 4, we can see that now our intrapulmonary pressure becomes greater than our atmospheric pressure. And because we know that a pressure difference needs to occur in order for air to flow, air is going to move out of the lungs. Our thoracic cavity collapses, our diaphragm relaxes back to its dome shape, the volume in the alveoli decreases because the sacs are deflating, so the intrapleural pressure, remember that's the pressure inside the alveoli, is going to increase back to its 756 millimeters of mercury, and again stay 4 millimeters of mercury less than the intrapulmonary pressure. And the cycle continues when we want to breathe in again. Ultimately, the natural elasticity of the chest wall opposes the inward pull of the lungs, resulting in the outward pull being slightly greater than the inward pull, creating that negative 4 millimeters of mercury intrapleural pressure relative to intrapulmonary pressure.
Boyle's law explains that pressure and volume are always inversely proportional at a given temperature of gas. At a constant temperature, the pressure of a gas varies inversely with its volume, so it's opposite. When at a constant temperature, if volume increases, then pressure will decrease, and if volume decreases, then pressure will increase. So applying Boyle's law to breathing, gases always fill their container. So if the container in this case is the lungs and the volume is increased, then the pressure will decrease, which is known as inspiration, breathing in the oxygen. If the volume of the lungs is decreased, then the pressure inside the lungs is increased. This is expiration, also known as breathing out the CO2.
The first factor is lung compliance and elastic recoil of the lung. Compliance depends on the elasticity and surface tension of the lungs. Compliance is inversely related to the elastic recoil of the lungs. So, thickening of the lung tissue will decrease lung compliance. The lungs must also be able to overcome the force of surface tension from water on lung tissue during inflation. In order to be compliant, and greater surface tension causes lower lung compliance. Therefore, surfactant secreted by type 2 epithelial cells increases lung compliance by reducing the force of surface tension.
Airway resistance is another factor that affects pulmonary ventilation. In healthy lungs, airways offer little resistance, so air can flow easily into and out of the lungs. If we increase resistance, we decrease airflow, and vice versa. Poiseuille's law represents how the flow of air passing through the airway is affected by 4 factors: the radius, length of tubes, viscosity of gases, and pressure. It tells us that a change in any of these factors will impact airway resistance by either increasing the resistance or decreasing it. It's important to understand that air must be moving under laminar flow, which means it's traveling in a controlled manner straight through the air tubes and not bouncing off the walls in turbulence. One of the most important factors influencing airway resistance is the diameter of the airway. When the radius decreases, called bronchoconstriction, there is less space available for air to flow, thus airway resistance increases. In the respiratory tract, the radius of the airways becomes smaller and smaller as air travels deeper into the lungs. Therefore, the resistance to airflow in the bronchioles is much larger than the resistance to airflow in the trachea. So what does this mean for us as healthcare professionals? We are worried about patients who have constricted airways and increased resistance to airflow. Alveolar surface tension is another factor that influences pulmonary ventilation. Surface tension is the force exerted by water molecules on the surface of lung tissue as the water molecules are highly attracted to one another and try to cram together, producing the smallest surface area possible. Because the air inside the lungs is moist, there is considerable surface tension present. but we can't allow for this to go on for too long, since the alveoli do not resist surface tension on their own. They could collapse. So surfactant is secreted and interferes with the water attraction to reduce the surface tension. When we take a deeper than normal breath in, more surfactant is produced to help the alveoli overcome the surface tension exerted by water so it can increase in size, filling up with air. Diaphragmatic and pursed lip breathing exercises can help to improve the rates of pulmonary ventilation.